Good evening. Am I audible? Hello?
Yeah, very audible.
Okay. Respected President, dear AMS members, senior doctors, friends and colleagues. I'm really glad to welcome you all to this AMS Revisiting the Basics session. This is the fourth program the great AMS chapter of IMA Trivandrum branch is conducting. That includes a one-day workshop on National Cardiac Life Support Program. We have 3 more programs in the pipeline for this month of March. On 23rd is the AMS practice changing updates dealing with tuberculosis. On 27th is the AMS Journal Club. And in between, on 25th, we are organizing a basic pulmonology workshop. It's going to be a fantastic one, a must-attend session for all those who are managing COPD, asthma, and all the pulmonary problems. And we have applied for the CME credit hours as well. Well, coming back to today's session, my duty is to welcome you all. I'm really glad to welcome our president of IMA Trivandrum branch, Dr. G.S. Vijayakrishnan, who makes it a point to attend all the AMS sessions, giving us a lot of support, encouragement, and direction. Thank you and welcome, Dr. G.S. Vijayakrishnan. And today, we're dealing with a very interesting topic. Statins, Bane or Boon. We are the best person to deal with the topic, to tell us whether it is a Bane or Boon. Dr. Scaria Thomas. He is the associate professor, the Department of Pharmacology, Government Medical College, Alappuzha. He's an excellent academician with MD in Pharmacology and MD in General Medicine. I welcome you, dear Dr. Scaria Thomas. And Dr. Anand, our convener, he's a member of our AMS family. He's yet to join. I think he's on call today in the hospital, but he'll be joining. He'll be dealing with the discussion part. And I welcome Dr. Anand as well. And I welcome all the senior leaders, all the AMS members, and all other participants. Now I request Dr. G.S. Vijayakrishnan to say a few words.
These programs, as already said, include regular CMEs, clinical club, journal club, workshops, and programs named Enriching Ourselves, intended to improve the basic medical knowledge. Today, we are going to have a session on statins to be presented by Dr. Scaria Thomas, who is the Associate Professor of Department of Pharmacology, Government Medical College, Alappuzha. I want to say a few words regarding the recent IMA activities, especially regarding our medical strike on 17th of March. As all of you are aware, that nearly 60 organizations participated in the historical strike on 17th of March. This includes the service organizations of government sector, then organizations of doctors working in corporate sector, doctors working in small hospitals and clinics, and also almost all specialty organizations. So these organizations, along with the organizations representing the private hospital management, organization representing the private laboratory management, and also Indian Dental Association. It was a great show of solidarity among modern medicine doctors. We will continue our fight against hospital attacks. As the president of Trivandrum branch, I thank all members for the huge participation in the strike. The strike was evident in all hospitals across Trivandrum city, that include government medical college, RCCs, REIT and all, and almost all private and government hospitals. In the future also, I request the support of all of you in dealing with such hospital attacks or any other issues related to modern medicine. And one more request from my part. I request all of you to go through the explanations compiled by KGMCTA regarding the recent controversy put forward by one political person related to treatment of a lady. All aspects regarding the efficient treatment given to the patient is scientifically explained in that document. I request all of you to forward the document to all groups, including non-medical groups. I'm concluding here, wishing all success for this academic session and thanking Pradeep Kadangur sir and Anand Marthandapulle for excellently organizing AMS programs. Thank you, JIM.
Thank you, Dr. Vijayakshan. And now I request Dr. Scaria Thomas to start the academic session. Over to you, Dr. Scaria Thomas.
Okay, sir. Sir, am I audible and is the screen visible?
Yes.
Okay.
Yes.
Okay. First of all, let me thank IMA Trivandrum AMS for giving me this opportunity. So we'll straight away go into the topic, statins, Boon or Bane. So first, before going into the topic, we should understand what is high intensity versus low intensity statin. So most of the studies generally just mention that it is high intensity versus low intensity. They don't really say what is the exact dose of the statin being used. So for that reason, we should first understand what is high intensity versus low intensity. So in this table by the ACC, American College of Cardiology, American Heart Association, you can see that high intensity statin is any statin dose which lowers LDL cholesterol by more than 50%. So you can see here that atorvastatin 80 and 40 and rosuvastatin 40 and 20 are generally classified as high intensity statins. About moderate intensity and low intensity, there is a lot of confusion because you can see here that Rosuva 5 it can act as a low intensity as well as moderate intensity. So that we will leave because most of the time we are confused whether we should start high intensity or any moderate to low intensity. So high intensity means atorva 40 or 80 as well as rosuvastatin 20 or 40 milligram. Okay, so other things it's not available here. So we are not going into all those details. So first of all, what we should understand is some people have a doubt whether LDL cholesterol lowering really matters. So some people say LDL is naturally produced in the body. Is there any need to lower it, and so on. So here is actually data from a meta-analysis published in Lancet 2005 by the Cholesterol Treatment Trialists Collaboration. It involved total participants of 90,000 participants from 14 RCTs of statins. So on the x-axis, you can see the mean 1-year cholesterol difference. So due to the treatment, what is the magnitude of cholesterol lower? That is on the x-axis. And on the y-axis, you can see the proportional reduction of major vascular events. So most of the studies, use millimole per liter. So to convert millimole to our usually we use milligram percentage or milligram per deciliter, you have to multiply it by 38. So if you see this graph, this is the one millimole per liter. So a drop of 1 millimole per liter of cholesterol, LDL cholesterol due to treatment, you see what is the benefit? See the benefit? A proportional reduction of major vascular events by 21 to 22%. So that is the significance of lowering statin. So you lower the statin, it doesn't really matter what was your initial value. Whatever be your initial value, if you lower statin by 1 millimole per liter, that is 38 milligram per deciliter, you can lower your risk for major vascular events by 21 to 22%. So major vascular events mainly means MI, stroke, then revascularization and death due to any coronary event. As you go up the ladder, you can see that you can attain greater benefits using this same approach that we'll see. So this is a forest plot which is showing the benefit. So here you can see that when you take this, I have underlined here. See, on the rightmost side, you have the relative risk. So relative risk reduction over a period of 5 years from starting statin treatment, you have a 0.8 is the relative risk reduction, relative risk when you are using statin, and when you are reducing the LDL cholesterol by 1 millimole per liter, the relative risk of the statin population for a major vascular event is 0.8. What does that mean? Relative risk of 0.8 means you get a 20% reduction in the risk of major vascular event with statin when compared to control. So that is for the total 5 years. If you're in the first 5 years, if you're leaving out and taking the second to 5th year, that is after 1 to 5 years, if you're taking the risk, the relative risk with statin population is 0.76. It means that there is a 24% reduction in the risk of major vascular event when you are using a statin to lower your LDL cholesterol by 1 millimole per liter. So you know that the lower you go, the better the benefit is, as well as the longer you take statin, the more the benefit you are going to accrue. Then I told that there is the benefit you can get doesn't really depend on your initial LDL value, but it depends on another aspect. It depends on your initial baseline risk. So in this chart or in this graph, you can see I have pointed my arrows to 3 bars. So what are these 3 bars? These 3 bars correspond to people in the highest risk. So here you can see more than or equal to 30% 5-year risk of vascular event. In these people, how many lives you can save if you lower the LDL by 1? In those who are having more than or equal to 30% 5-year vascular event risk, if you lower the LDL by 1 millimole, that is 38 milligram percentage, you can save, if you give to 10,000 patients for 5 years, you can save 730 patients. If you lower by 1.5, you can save 1,130 patients. And if you lower by 2 millimole per liter, that is around 76 milligram percentage, if you are lowering the LDL in patients with high risk, that is more than 30% risk of vascular event, if you are lowering it and you maintain that lower level for 5 years, in 10,000 individuals, you can save 1,440 deaths, or death, or like an MI, stroke, revascularization, or death. So a major vascular event, the reduction of the major vascular event risk depends on your initial baseline vascular risk. So if you are high risk, your benefit is more. So then there is a doubt whether should you go with high intensity or should you go with low intensity statins. So that benefit or risk was examined by a cholesterol treatment trialist collaboration meta-analysis, which included 170,000 participants from 26 RCTs. It was published in Lancet in 2010. So when compared with less intensive regimes, further reduction in LDL cholesterol at 1 year was 0.5 millimole per liter. So initially I told you that there is difference between high intensity and low intensity. High intensity is a statin. High intensity statin is a dose of statin which can reduce your cholesterol by more than 50%. So if you are using a high intensity statin, you can further reduce your cholesterol at 1 year, LDL cholesterol, by 0.5 millimole per liter, or which approximately comes to 19 to 20 milligram per deciliter. And as I mentioned earlier, for every 1 millimole reduction in LDL, there is a relative risk reduction of 22%. So if you are using a high intensity statin and you lower your LDL by 0.5, so if you are using a moderate or low intensity, it will not be lowered by that much. So when you are using a high intensity, in addition to the normal lowering by less intensive regimes, you are able to achieve a 0.5 millimole per liter further reduction in cholesterol. So what will that lead to? You can further save lives. So for 1 millimole reduction, you can reduce the relative risk by 22%. So proportionately, if you are lowering using a high intensity by using high dose of statin, if you are reducing your LDL cholesterol by a further 0.5 millimole, you can reduce your cardiovascular risk or major vascular event risk by approximately 10%, because 1 millimole corresponds to 22%. So approximately 0.5 millimole will approximately correspond to 10% reduced risk of major vascular events. So some people may doubt, so should I take high intensity versus low intensity? So, or should I am now on a less intensive regime, should I go, so like for example, I am now taking Atorva 20, should I increase my dose to Atorva 40? So if you are going to increase your dose, what will happen is that you can further get a reduction of 0.5 millimole and further reduce the vascular event risk by 10%. So that is the advantage. So that advantage of reducing your vascular event risk by 10% should be weighed against the adverse effects of high intensity statins that we will see. So one important adverse effect that was seen in this cholesterol treatment trialist collaboration, which we are all afraid of, is the observed excess of rhabdomyolysis was 4 per 10,000 in trials of more versus less intensity statin therapy. But the problem is this was with simvastatin. So simvastatin is notorious for rhabdomyolysis. The risk of rhabdomyolysis with simvastatin is the maximum. It is less with atorvastatin. It is even lesser with rosuvastatin, because rosuvastatin is not lipid soluble. It is water soluble. So it doesn't really go into the muscle so fast. Okay, this is a forest plot. This not same thing which I mentioned earlier, not going into that, maybe a bit complicated. Okay, so next question, again, everybody is having a doubt. How low can you go? How low can you go? That is again a question which people are confused. Like people used to say, like previously, initially it was LDL target was less than 100, then became less than 70, like that. So how low can you lower the LDL cholesterol? So this was examined in a meta-analysis published in JAMA Cardiology 2018. Efficacy and safety of further lowering of LDL cholesterol in patients starting at very low levels. So the question they asked was, is the clinical benefit of LDL cholesterol lowering preserved in patient population starting with an LDL cholesterol of 70? or less, and is the LDL cholesterol lowering safe in such patients? So here they are examining patients who are having a starting LDL cholesterol is 70. It's not like 150, 160 or anything. Their starting LDL cholesterol is 70. And then they are further reducing the LDL cholesterol. Is it going to reduce the risk of major vascular event? This is what they examined. So in that trial or in that meta-analysis, they found that for statins and non-statins, so they actually not just measured statins, they actually checked other drugs which can lower the LDL cholesterol, like a combination of statin plus ezetimibe or PCSK9 inhibitors. So for statins and as well as non-statins, the reduction of major vascular events was significantly reduced by 21% for each 1 millimole reduction in LDL cholesterol and was not associated with increased risk of serious adverse events, myalgias, myositis, or any of the mentioned adverse effects. So what do we understand from that? So it means that even if the patient's starting LDL cholesterol is 70 or less, still if you lower it by 1 millimole, you can get around 20% relative risk reduction. So doesn't matter what your LDL cholesterol is it 150, 160, 120, 100, 80 or 70 or 60, if you lower your LDL cholesterol by 38.7 milligram per deciliter, you can get a 21% reduction in the major vascular event risk. So there is a relative risk reduction of 21% for each 1 millimole, even if your starting cholesterol is less than 70. So, and also not only that, we are all afraid when we are lowering LDL cholesterol to very low, will there be any problem? So these patients were followed up for a period of, most of these studies had a follow-up period of 5 years. So over these 5 years, they saw that there is no risk of any significant difference in the adverse events also. So that is actually a very nice finding. And also another important point to remember is how low can you go? There is another thing is, this is how low can you start? How low can you go? So I have not given all that data into this because that would be too much. But as per the studies, they have conducted studies where your final LDL cholesterol have been lowered up to even 30 or even 20 milligram per deciliter. So even at those levels, patients are getting continued benefit without adverse effect. So you can lower your LDL cholesterol to even up to even 20 or 30, but that is only some study data is there. Nobody has actually issued any guideline that you can reduce it to that much, but you can reduce it from 70 to, I would say it is from 70 to 35 till around 30, it is okay, because most of the studies, they have a final value of around 30 milligram per deciliter. So till that value, most of the studies are, the results is in that range. So, and there is no significant increase in adverse effects. So you can lower it up to 30. So now we have seen the benefits of statins. So why is it, we have seen the benefits of statin. So just to summarize in 1 or 2 words. So what is the benefit of statin, or what it is that it can lower your LDL cholesterol. And now what is the benefit of high intensity versus low intensity statin? A high intensity statin can lower your LDL cholesterol by further lower the LDL cholesterol by 0.5 millimole, that is around 38 milligram per deciliter. And what is the advantage of lowering LDL cholesterol? Each 1 millimole reduction in LDL cholesterol will reduce the major vascular event risk by around 21 to 22%, depends on the study. So I hope you have understood the benefit. And also, most of these studies do not show a significant increase in the adverse effect. That is, RCTs do not show any major significant increase in any major adverse effects. Also, myalgia and all those things are there, which we will see. So now we will see about the adverse effects. So what is statin intolerance? That is a term. It's an inability to tolerate a dose of statin required to reduce the person's cardiovascular risk sufficiently from their baseline risk. So it is seen that 50% discontinue within 6 months of starting. So it is not because of the adverse effects. So you will think, when you see this data, you will think, oh, more than 50% are developing adverse effects. So actually that is a very bad thing, but actually no. These more than 50% discontinue because of the fear of adverse effects. That is the most important thing. Plus, they may not want, they may think, oh, I don't have any cholesterol is good and all those kind of talks which we hear on YouTube channels. So people will be maybe thinking of that. But more than 50% discontinue, that is a fact. And also a good number of them, a majority of them discontinue because of the fear of adverse effects, not to do the adverse effect. So what are the important adverse effects? Actually, statins have so many adverse effects, which are like, I'm not going into the minor nausea, vomiting kind of thing, which students write on their answer sheet. So what we are concerned is about the major or the important adverse effects of statins, which we should be concerned when we are prescribing. So we don't want any complication to develop in our patients, or when we take statin, we don't want any complications to develop. So what are the major things we should keep in mind? They are mainly 4, that is statin-associated muscle symptoms, abbreviated SAMS, statin-induced liver injury, new onset diabetes mellitus, abbreviated NODM, and hemorrhagic stroke. These are the things we want to know. What will happen? Okay, I am getting so much benefit, but will I have any problem if I take statin? Especially if I take high intensity, that we'll see. So the most common cause of discontinuation I mentioned. So it is SAMS can include myalgia, myopathy, myositis with elevated creatine kinase, and its most severe rhabdomyolysis. So myalgia means just muscle pain. These are definitions in the clinical trials. Okay. So myopathy means muscle weakness with elevated creatine kinase, 10 times, above 10 times upper limit of normal, but below 100 times upper limit of normal. Myositis with elevated creatine kinase is self-explanatory, and rhabdomyolysis, as you all know, is acute kidney injury because of the very much elevated creatine kinase, usually above 100 times upper limit of normal. So these adverse events, that is the SAMS, usually occur within 1 month of treatment. It is thought to be because of the effect of this statin on the impaired electron transport chain, as well as oxidative phosphorylation, and resulting in mitochondrial dysfunction. So the muscle is not able to produce that much of energy because of the impairment of the electron transport chain as well as the oxidative phosphorylation. That is why you are getting these muscle symptoms. 10 to 30% is what is the percentage given in literature. So we will think, oh my God, that is such a large number. So why is this such a large number? Not only is a large number, the variation, see 10 to 30%. Why is there so much variation? This is the reason for the so much variation. Because statin-associated muscle symptom is a broad term. Like I told, it can have myalgia, muscle spasm, muscle cramp, muscle pain. That is very common. So that can come up to around 10-20% is due to that. Then comes the uncommon. Uncommon means less than 1%. That is myopathy and myositis. Then comes rare to very rare. Very rare is less than 0.01%. That is okay, or less than 1 in 10,000. That is rhabdomyolysis. It is very rare. It is the rhabdomyolysis incidence is 0.002%. So it is very rare. We will see a few studies which examine the SAMS. Just to make you, those who are viewing, they would need some evidence. So what I am saying is based on evidence. Now is the era of evidence-based medicine. So everybody wants evidence. So I'm telling you, showing some selected studies. A lot of studies are there which give this data. Just some important studies which I found very convincing that I am showing you, which with adequate sample size, reasonable follow-up period and all that I am showing you. So this is the ASCOT LLA study, a trial, which was a randomized double-blind placebo-controlled trial, followed by a non-randomized non-blind extension phase. So it means that 10,180 patients were randomized to either a statin or a placebo for 3.3 years. So those 3.3 years was blinded, followed by 2.3 years, which was non-blinded. So what do you mean by blinded and non-blinded? I think all of you know. So in this context, it means that during the first 3.3 years, patient didn't know whether he was taking statin or placebo. Followed by the next 2.3 years, patient is told, okay, you are taking statin, you are taking placebo. That is the extension phase. So muscle-related adverse events were 2.03% per annum in atorvastatin 10 mg. So they use 10 mg, okay, it's low dose only, versus 2% in placebo. So what do you understand? There is no significant difference, very minor difference between the atorva and the placebo. This was during the blinded 3.3 years. Then what happened when the blinding was removed? the incidence of SAMs increased to 1.26% versus 1% per annum. So it's not increased. The incidence of SAMs with statin was significantly more when compared to the placebo. So placebo people had only 1% per annum, whereas those people who knew they were taking statin, they were having 1.26 per annum, which was significant difference. So why is this? So when they were not told what they are taking, there was no significant difference. But when they were told they are taking statin, they are having significant difference in the SAMs. This is thought to be due to an effect called the nocebo effect. All of you know about placebo effect. So what is placebo effect? Placebo effect means the benefits are there, patient is getting benefits because of his positive expectation. So he is thinking he'll get benefit, he's getting benefit due to a treatment. What is nocebo effect? He is developing adverse effects because of his negative expectation. So he is thinking, oh, I am taking statin, oh, and all over the literature or media, it is there, statin is having that problem, this problem. So then he'll take and he'll actually, attribute all his muscle pain due to the statin. So that is the nocebo effect. So nocebo effect is patient expectation of harm resulting in perceived side effects. So this was examined by 2 trials, that is Samson study as well as a statin-wise study. So I'm only mentioning about Samson study. Statin-wise also very similar study. So in the Samson study, which was published in 2021, it included 60 patients who were, it was actually crossover trial, multiple crossover protocol. It means that there were 3 interventions. So atorvastatin 20, placebo or no treatment. These were the 3 interventions. So patients were given these 3 interventions over a period of 1 year. Each intervention duration was 1 month. So 1 month you give, so these same patients, 60 patients, each patient is receiving, suppose they are starting atorva, then placebo, then no treatment. The next patient will be starting placebo, no treatment, atorva. The another patient will be starting no treatment, atorva, placebo, like that. So these patients were followed up for a period of 1 year, and every month their medicine was changed to atorva or placebo or no treatment. So finally, they analyzed and they understood that 90% of the muscle pain or muscle weakness attributed to statins were elicited by placebo tablets also. So placebo is also producing pain. That is what the 90% of the pain is due to attributed to statins were elicited by placebo also. These patients didn't know what they were taking, whether they were taking statin or placebo, they didn't know. No treatment, obviously they will know. Stopping was no more frequent for statins than placebo, and subsequent symptom relief was similar between statin and placebo. So at 6 months after the trial, 30 of the 60 participants were back taking statins. So what you should remember is that the 60 patients who entered the study, they were patients who had discontinued statins previously because of musculoskeletal symptoms. They were patients who stopped statin and they were not taking statin. They didn't want to take statin, but somehow they were convinced to join this trial and they completed this 1 year full trial. After the trial, 6 months after the trial, when they were contacted, 50% of them were back taking statins. Why? Because they were convinced that this is the muscle pain they attributed to statin was actually not due to statin, but due to the nocebo effect. So this is just some patient pattern which was seen in this study, that is Samson study. One group of patients were having ever-present background symptoms. So this, you can see this graph. In this graph, x-axis is the intensity, y-axis is the time. Each block corresponds to 1 month. Blue is placebo, gray is no treatment, red is statin. So in patient, and these are only the patient data of 1, 2, 3, 6 patients. Total 60 patients are there. Just like they are giving a example how people behave or how muscle symptoms occur during the study. So this is this first patient 10. First month he was given placebo. He is having muscle pain or SAMS, some problem is there, muscle myalgia, muscle cramp, something. Second month he is getting no treatment, still he is having. Then third month he is having statin, still he is having. Then placebo, then no treatment, placebo, no treatment. Every month he is having same pain, irrespective of whether he is on statin, placebo, or no treatment. These are called ever-present symptoms, background symptoms. These two, patient 28 also same. Next is successful re-challenge. See, patient 53 and patient 11. I told you all these patients were patients who discontinued statins previously. They took statin previously, then they thought it's not good, then they don't want, but then when they entered the trial, they were given statin and they didn't develop symptom. Then see the third group, nocebo effect. Initially they didn't have any symptom, but then on taking, see the patient 45 started on placebo, and around the 6th month, he developed symptoms. Then he is continuously having symptoms, whether on statin, whether on placebo, everything he is having symptoms. Then see patient 26. On placebo, he developed significant symptoms. When he stopped the placebo, he got relief. Then again, when he took statin, he got significant symptoms. When he stopped the statin, he got symptom relief. So what does that mean? Placebo and statin are producing symptoms, and stopping placebo and stopping statin both produce relief of symptoms. This is the nocebo effect. Then meta-analysis published in the European Journal of Preventive Cardiology, in which they analyzed 46,262 patients with primary prevention RCTs in primary prevention RCTs and 37,618 in secondary prevention RCTs. In this trial, but the drawback was that only few trial data with high dose atorvastatin was included. But whatever it is, ultimately they found that only a small minority of symptoms reported on statins are genuinely due to statins. Almost all would occur just as frequently on placebo. So from all these trial data, what do we understand? We can understand that that is based on the Ascot LLA, the nocebo statin, the Samson statin wise, in this meta-analysis. What do you understand? That the significance of muscle symptoms is not that much high, especially when they are used, when we are using low dose statins or low intensity or moderate intensity. But when we go to high intensity statins, say 80 milligram simvastatin and all, you can see that there is a 0.9% in that versus 0.03 myopathy. So myopathy with high dose simvastatin is significantly more. See also rhabdomyolysis 7 versus 0. Each arm had 6,000 patients. Out of 6,000 patients followed for 7 years with 80 milligram simvastatin, 7 developed rhabdomyolysis. 20 milligram, 0 rhabdomyolysis. So this means that high intensity statin, if you are giving, you can develop some significant muscle symptoms. But that is also very small percentage, so only 0.9%. That also over a period of 7 years. So that is not a very significant number, but still you have to keep it in mind. Rhabdomyolysis is also 7 over 6,000 patients for 7 years. When you follow on 80 mg, you develop 7 rhabdomyolysis. So this is another PRIMO study, it's a French study. In this, the point to remember is what you should understand is simvastatin 18.2%, atorvastatin 14.9%. So what you should understand from all this is that when you are using high dose statins, there is a high incidence of muscle symptoms. This is not myopathy, this is general muscle symptoms. When you are using a low dose statin, the incidence of muscle symptoms are very less, like 5% like that. But when you're using high dose, like high intensity, 40 to 80, you are developing high percentages of muscle symptoms. This is not myopathy. Myopathy, like previous slide, see only 0.9%. This is muscle symptoms, any muscle symptom. So, but more with simvastatin, but we don't use simvastatin. So, atorvastatin also has some significant 14.9% over this when you are using this drug. So to summarize about SAMS, that is the statin associated muscle symptoms, to summarize, to understand what is the significance. Treatment of 10,000 patients for 5 years with an effective regime. Effective regime means, like more commonly we use 40 mg atorvastatin daily, has been suggested to yield 5 cases of myopathy, of which one may progress to rhabdomyolysis if treatment is not stopped. So the 10,000 patients, you are giving 40 mg atorva daily for 5 years, you may get 5 myopathy, not muscle symptoms. Muscle symptoms may be there, maybe due to nocebo effect, maybe due to the drug. But 5 cases of myopathy, which means muscle weakness with elevated creatine kinase level more than 10 times of upper limit of normal, of which one may progress to rhabdomyolysis only if the treatment was not stopped. So suppose the patient is coming with muscle pain, myalgia, and you check the creatine kinase, it is elevated. If you still continue, patient may develop rhabdomyolysis, but nobody does that. When we see it, we stop. Okay. So factors which may worsen SAMS, this we should remember. Past history of recurrent muscle symptoms. So some patients have recurrent muscle symptoms, maybe due to some SLC gene mutation. Various gene mutations are there which can lead to minor muscle symptoms. So that if there is there, then better not to give statin or start with the low dose and then increase it. Elderly, obviously elderly have low muscle mass, they can develop symptoms, and also they may have hepatic renal dysfunction. So vitamin D deficiency, some studies show vitamin D deficiency associated with SAMS, increased incidence of SAMS. Hypothyroidism also, some studies show increased incidence with SAMS. Food and drug interactions. Drug interactions are there with statins, especially with atorvastatin, because it is metabolized by CYP3A4. Rosuvastatin is not much metabolized by the liver. It is mainly excreted through the kidney, so not much of a drug interactions, but still these drug interactions are there. So what are the important drug interactions we should remember? Most importantly, what we should remember is enzyme inhibitors, that is macrolide antibiotics, azole antifungals, protease inhibitors, and also we should also keep in mind about cyclosporin, which can also produce a enzyme inhibition. Then food, actually most important is grapefruit juice. So we see in textbooks as grapefruit juice causing muscle symptoms. So we think grapefruit is grape, but grapefruit is not grape. It is like, looks like orange. That is the image I am shown here. So this is grapefruit. So the juice of this taken in large quantities, just one glass is not going to produce anything. Large quantities can significantly lead to statin-induced myopathy. Another important interaction is fibrates. If you give statin with fibrates, there is a high chance of developing myopathy. This is an adverse effect seen in the literature, immune-mediated necrotizing myopathy. Basically, it is a myopathy. But what is the problem? So patient comes with pain, you check creatine kinase, it is elevated, you stop the statin, still it is not going on. That pain, weakness, elevated creatine kinase is persisting. That is immune-mediated necrotizing myopathy. It is thought to be due to an autoimmune phenomenon, and so you need to give immunosuppressing drugs, steroids, methotrexate, even IVIG can be tried. So going on to the hepatic adverse effects. So the 1 to 10% is the common adverse effects. Of that, common is increased transaminases. Uncommon is less than 1%, persistent elevation of transaminases, and rare is liver injury. It is very rare, 0.019%. So transaminases can be observed in the first 3 months and it returns to baseline. So that, what does that mean? So it is actually a hepatic adaptation. When you are giving statin, the hepatocyte membrane, lipid membrane undergoes some changes, resulting in leaking of the hepatic enzymes into circulation. That is why patient is having this transaminitis observed for the first 3 months. It returns to baseline because it is an adaptation. The histological studies have not shown any significant damage to the liver due to this transaminitis initial 3 months. But 0.7% of those on atorvastatin experience persistent elevation of this aminotransferases more than 3 times upper limit of normal. So what we should remember is, it can occur, usually it starts in the first 3 months, but it can occur up to 1 year after starting statins. More common with maximal dose, that is high intensity, it is more common in patients with hepatic and renal impairment, and also with other, in combination with other hypolipidemics like fibrates, CYP, 3A4 drug, that is inhibitors, enzyme inhibitors, which I mentioned earlier. So those interactions are all there. High intensity is having more incidence. Hepatic and renal insufficiency is having more incidence. So in these patients, you should be very careful. And if you are finding a more than 3 times upper limit of normal elevation of the transaminases, better to stop. Even if you don't need to see whether it is persistent. Actually, persistent means you can follow up for 3 months or 6 months and see if it is remaining there like that. But in our current situation, it is better to stop the statin if you are finding a elevation. Just an elevation you find, you stop, and then after some time, once it comes down to normal, you can go for another statin. Suppose patient developed this statin-induced transaminases with atorva, you can go with rosuvastatin. But also, we should rule out other causes. Okay, and also it is better to do a LFT prior to starting high-intensity statins. Prior, not after. Prior, because the patient may say he developed this liver damage due to your statin treatment. So if you just check a LFT and keep it, then you know the patient is already having some problem. Then it is the patient's damage problem is not due to your statin treatment. Okay, and there can be rarely histological damage, hepatocellular or cholestatic damage. That is very rare. That is less than 0.1%. So these are some database analysis. Okay, so in the Swedish database, 1988 to 2010, see, there was only 30 cases were there, but only one patient died. In the Spanish hepatotoxic registry 1994-2012, only 47 cases. For 20 years, only 47 cases. In the US drug-induced liver injury network, over a period of 18 years, only 22 cases. And of that, only one patient progressed to CLD. So this is a very rare occurrence of this liver damage. And also, better if you are monitoring a patient with, when you are starting high dose, high intensity statin, you can easily pick this up. Then there is a rarely there is another condition called statin-induced autoimmune hepatitis, which is rare, and also in such patients you may get an ANA positivity, okay, or an anti-SMA positivity. Other than that, is actually not common, but these are the important problems with statins. So statin-induced liver injury is actually a very rare thing. There is nothing much to worry. But what you should remember is statin-induced transaminitis is common. So you monitor LFT for the first 3 months before starting, and first 3 months, especially when you are starting high intensity. Then most of the time it's okay unless the patient is coming with symptoms, anorexia, fatigue, abdominal pain, jaundice, like that. If patient is coming, you can check the LFT. Otherwise, no need. The treatment of 10,000 patients for 5 years with an effective regimen would cause 50 cases of persistent elevation of AST or ALT, more than 3 times upper limit of normal. So 10,000 patients for 5 years would cause 50 cases of persistent elevation. You stop that there, these will go back to normal. That is all. So new onset diabetes, that is again another important problem, which is having a high incidence. So very high, the percentage is very much high. So I will just mention some important aspects. So this is a study in which they were measuring the low dose statin. Low dose statin has a hazard ratio of 1.15, meaning 15% increase of new onset diabetes with low dose statins. 15% increase, okay. And the P was 0.00, so it is significant. In the Jupiter trial, it was an RCT 2008. Here they were using rosuvastatin 20, which is actually classified as a high intensity statin. Here the hazard ratio is 1.28, meaning 28% greater increase of diabetes with high intensity statin when compared to placebo. And the point to note from this study is, who develops diabetes with statin? Not everyone. Only those patients who are having high risk for diabetes risk factors like obesity, metabolic syndrome, fasting, that is impaired fasting plasma glucose, then high triglyceride more than 150. These are the risk factors in these patients, that is obesity, metabolic syndrome, impaired fasting glucose, fasting plasma glucose, elevated triglyceride more than 150. In these patients, when you are starting statins, you have a chance of patient has a chance of developing diabetes. In absolute terms, for every 54 new cases of diabetes diagnosed, 93 total cardiovascular deaths can be avoided. So you may think, if the statin is causing so much diabetes, should we give this in patients? So you see, for every 54 new case statin diagnosed, you are saving 93 lives. So maximum that can happen is you may diagnose diabetes, that you can treat, but if you don't give, what will happen? 93 patients will die. And this is for patients with high risk. If there are no major risk factors for diabetes mellitus, statin use saved 86 lives in this study. In this study, over a period of 2 years, when 8,000 people were given, they saved 86 lives in patients with no risk factor for diabetes. In those with risk factor for diabetes, statin use 93 total lives were saved for every 54 new case of diabetes diagnosed. So you can think of the risk versus benefit, and then you can decide whether should I give this patient statin or not. So obviously, it is easy to understand that there is nothing confusing that. Definitely we should start statin. In this trial, again another RCT, hazard ratio was 1.34, that is 34% increase. Here they were using 80 milligram atorvastatin. So see, hazard ratio 1.34 means 34% greater chance of developing diabetes, new onset diabetes with 80 milligram atorva. So another Finnish study, here it was a 5.9-year follow-up of 8,749 patients. Here they are diagnosed diabetes by oral glucose tolerance and HbA1c. Usually we don't do OGT for diagnosing diabetes, but in this study they used OGT for and HbA1c. Usually in the previous studies they were using fasting plasma glucose, or in some studies it was like diagnosis of diabetes by physician diagnosed diabetes. So maybe similarly by what we do by like fasting and postprandial only. But in this study they were using OGT. That is why you see the hazard. The diagnosis was also high. Hazard ratio was also 1.44. That is with high dose simvastatin 44% and with high dose atorvastatin 37% increase. Hazard ratio 1.37 means 37% increase in new onset diabetes with atorvastatin high dose. But they were very aggressive in diagnosing, like giving OGT and diagnosing. So we don't usually do like that. So what we can understand is that when we are using low dose, you get a hazard ratio of around 15 to 20% increase. When we are using high dose, it can go up to 30, 35, or even up to 40% increase. So treatment of 10,000 patients for 5 years with an effective regimen would cause about 250 new cases of diabetes. So this is the point to remember, 250 new cases, but you can say how much that will come. So 10,000 patients you are giving for 5 years with Atora 40, you may cause around 250 new cases of diabetes. This is the very important latest development, that is risk of hemorrhagic stroke. So till now, most of the studies were showing that hemorrhagic stroke increases with statin. But now, in 2020, a meta-analysis was published in stroke survivors of 33 clinical trials, and 2 lakh subjects were there. That is, it analyzed data from 33 clinical trials with a total of 2 lakh subjects. In this, you should see this value, that the frequency of intracerebral hemorrhage was 0.53% with high dose, 0.37% with low dose, and 0.32% with no statin. So in stroke survivors, when they did this, what they could understand is that the difference of hemorrhage with low dose statin versus no statin, that is 0.37 versus 0.32, was insignificant. Whereas high dose versus no statin is significant, 0.53%. So patients taking high dose statin treatment experienced an increased risk of developing ICH, intracerebral hemorrhage. It is relative risk 1.35 means 35% increase in risk. Whereas low dose statin did not significantly increase risk of intracerebral hemorrhage. More intensive versus less intensive statin therapy also indicated that total number of strokes were significantly reduced in the low dose statin therapy group and the high dose, that is a relative risk of 0.84, as well as in the high dose. So what we can understand from this, when we give statin in a patient with history of stroke, we always give statin in a patient with history of ischemic stroke. So when we give it, do like that, whether you give low intensity or high intensity statin, you can definitely reduce the risk of developing stroke in the patient, okay, by 14 to 15%. But if you are using low intensity, there is no significant increase in IC bleed. But if you are using high intensity, then you can develop IC bleed. Patient may develop IC bleed. So from that, what do you understand? Meta-analysis indicate that low-dose statin therapy reduced the risk of all stroke, ischemic stroke, and all-cause mortality without increased ICH. So all of you should remember this. That is, low-dose statin therapy reduced the risk of all types of strokes, then ischemic strokes, and all-cause mortality without increased intracerebral hemorrhage. So a patient with a history of stroke, you should start low dose. That is, when we are using atorvastatin most commonly, atorvastatin you start with either at 20, 10 or at 20. You can give 20 because that is okay. Don't straight away go to 40 or 80 because this meta-analysis says that the risk benefit is better with a low dose. Low dose means 10 or 20. 10 or 20 is they considered as low dose in this trial. This again not going into that detail. Okay, so this is a cohort study from Denmark, Danish cohort study. Here they analyzed 519,000 with stroke-free individuals. This is primary prevention. The previous study was secondary prevention. So when we give statin in already patients with stroke, this is patients who are not having any stroke or any problem. They were 519,000 with statin and 5 times that number for stroke-free reference subjects without statin. So very large patient sample size. This is a cohort study. So in this 1,409 intracerebral hemorrhage occurred in statin users, and statin users had an overall hazard ratio of 0.85. So you see this result. So this is a very large cohort. more than 5 lakh patients. They were followed up for 10 years in Denmark. So those with statin were followed up. Then 5 times that number of patients without statin were followed for a period of 10 years. They did some lot of statistical adjustment for various other confounding factors. And during this period, 1,409 intracerebral hemorrhage occurred in statin users. So we will think it is high. So what we are expecting? We are expecting a hazard ratio more than 1, because till now we were thinking statin increases ICH. But what is the hazard ratio? 0.85 means that 15% reduced risk with statin. So that is actually a very significant study. Actually, in the long run, I feel now newer and newer such cohort studies are coming up, which are saying that statin use reduces the risk of intracerebral hemorrhage. Understand? So actually, it's still not come out in due to in the guidelines, but I'm sure it will come out, because this is there are many studies, similar studies are there, which are showing that cohort studies which show that statin use reduces the risk of intracerebral hemorrhage. This reduction of intracerebral hemorrhage risk could not be explained by differences between users and non-users in terms of various other confounding factors. They also adjusted for other drugs which the patient was taking, other comorbidities which these two groups were taking. They adjusted for everything, but still they could not explain why these patients on statin had a reduced risk. So finally, what is the conclusion? It is due to statin. The reduced risk is due to statin. This is the image. This is the graph. You see, first 6 months, risk is increased. That is normal, like ischemic stroke. Hemorrhagic stroke is this black line. Ischemic stroke is this light line. So this first 6 months you see after starting gradually comes down. Once the 6-month period is over, you see both hemorrhagic and ischemic stroke risk is has come down. So first 6 months, there is no increase. Definitely it is coming down, but after 6 months, see the hazard ratio going below 1, means those on statin are getting more benefit due to statin. So summary. So finally, we are last 2-3 slides. So you see, you analyze this summary and then you decide whether you want to give statin. The slide may look a bit congested, but I'll just tell you how to read this. So if you are lowering, so you take 10,000 patients, you give them atorvastatin 40 milligram daily for 5 years to achieve a LDL cholesterol lowering of 2 millimole per liter. So this is the patient population. You take 10,000 patients, you give them atorva 40 for 5 years to achieve an LDL cholesterol lowering of 77 milligram per deciliter. Then you follow these patients at 5 years. What is the benefit you get? You can save 1,000 patients because of giving statin in those patients who had pre-existing vascular disease, that is secondary prevention. And already patients who are having CAD, stroke and such peripheral vascular disease or whatever, if you give statin, you can save 1,000 patients out of this 10,000. In primary prevention, that is, they do not have any vascular, no history of MI, angina, stroke, TIA, peripheral vascular, nothing is there. You give them statin, you can save 700 patients out of this 10,000. Now, what is the risk? You see in the last paragraph, 5 cases of myopathy can come. Okay, 5 cases. That is, so once you get myopathy, what will you do? You find a patient, you stop that. So that is solved, that is over. 50 cases of persistent elevation of AST bar ALT more than 3 times. That also, if you monitor, you can pick up. Even if you don't monitor, patient is coming with some symptoms, you pick up, you stop that. That is also gone. There is no need to worry about that. 250 cases of new diabetes. That is one problem which you may think. Like 250 patients are developing diabetes. But see the benefit. 250 are developing diabetes, but see 700 patients you can save. This is developing diabetes only, no, you can treat it, no problem. Here 700 patients you can save, and in secondary prevention you can save 1,000 patients. So will you start? Yes, definitely we'll start, because you can save 700 patients here, 1,000 patients. Maximum you will get is 250 new cases of diabetes. That you can treat, that you can manage. And 5 to 10 cases of hemorrhagic stroke. That again is controversial, because now studies are showing there is no much risk of hemorrhagic stroke. So overall, what do you understand from this? Overall, using statin is very significant, produces very significant benefit to the patient. Also in stroke prevention also, you can see that in stroke prevention, 1 millimole per liter reduction can reduce the risk of stroke by 21%. Just like in CAD, 1 millimole per liter, that is 39 milligram percentage can lower the risk of stroke by 21. Then pleiotropic effect of statins is a term which has fallen out of favor. Previously, they used to say that it has benefit in cancer, it has anti-thrombotic property, anti-platelet property, antioxidant property, anti-inflammatory property, but none of these are proven. Data is very confusing. Nowadays, nobody mentions anything about pleiotropic effects of statins. Interactions I mentioned, all of you watch for these interactions while prescribing, that is fibrates. Be very careful. Cyclosporin is an enzyme inhibitor, azole an antifungal enzyme inhibitor, macrolides enzyme inhibitor, protease inhibitors given for HIV and hepatitis C also, like glicapravir, cimipravir, and all those. Be careful. Grapefruit juice. It's not grape juice, it is grapefruit juice. So be careful while ask the patient to avoid this, or if you are finding some interacting drugs, replace with some other drugs. So practice pulse. Low intensity statins are safer, obviously. High intensity is also safe, don't worry, but proper monitoring. I would say before starting at Atorva 40 or 80, if possible, do an LFT. Then, if possible, do an LFT at least in the first one time in the first 3 months. That is the minimum. Okay. Avoid drug interactions, like I mentioned. Avoid alcohol. Alcohol can further damage hepatic, that can induce liver damage by itself. So you take statin, it can worsen. So those on statin, better avoid alcohol. Caution in renal dysfunction. So renal dysfunction, actually, it is said caution. There is no problem in giving statins in renal dysfunction. Actually, the KDIGO guidelines say that you should give statin in patients with above 50 years and CKD. Above 50, so KDIGO guidelines say that above 50 years with CKD, you should give statin because CKD itself is a major cardiovascular risk factor. But it is not useful in patients with on dialysis. So on dialysis patients, no use with statin. But CKD, patients above 50 years, you give statin. If you actually, KDIGO says even if lipid profile LDL is not elevated, you give. But practically, only if LDL is elevated, we give statin. That is for CKD. Then contraindicated in CLD patients with AST bar ALT more than 3 times upper limit of normal. But point to remember is studies are now showing that statins can slow down fibrosis in patients with NAFLD. So that is again another point which you should keep in mind. So you think of the risk versus benefit. So if a patient with NAFLD comes and you think that they can benefit with statin, you can give statin if the AST or ALT is less than 3 times upper limit of normal. Contraindicated in pregnancy and lactation, that always keep that in mind. And rule out underlying causes of liver injury. Patient comes with liver injury, don't attribute everything to the liver, the statin. It may be due to some other thing, viral hepatitis, some autoimmune hepatitis. Then nowadays everybody is taking all these not to Vaidyam and all. It may be due to that and all. Then in patients with statin-associated muscle symptoms or liver injury, an alternate statin may be tried. So just because a patient has symptom with statin, just don't tell them, oh, you can never be started on statin. Actually, you stop it once the symptoms reduce. If it was due to Atorva, try Rosua. If it was due to Rosuvastatin, try Atorvastatin. But when re-challenging, start with a low dose. That's all. Thank you.
Thank you, Dr. Scaria Thomas. It was an excellent session. Now I request Dr. Anand to start the discussion.
Thank you, sir. Am I audible?
Yes, yes.
Okay. Thank you, Dr. Scaria, for a very exhaustive coverage of the topic. A lot of data, very nicely analyzed with informative summary and spoils. I think we will start with some of the questions in the chat. Scaria, are you able to see these? I was able to see, but now I can't.
Yes, I can see. Let me see. How about statins in pediatric age group, especially pediatric metabolic syndrome? Pediatric, this American College of Cardiology AHA guidelines, they took 20. Starting statin about 20 years only they have mentioned. Less than 20 years they have not clearly given about the benefit of statin. So that is still a controversial area. You cannot really, I cannot comment about that because no guidelines exist less than 20 years. About 20 up to age of 75, 79 years, you can give statin. So pediatric data is not available. And I don't know what are the indications to start on statins. Is it exclusively based on high cholesterol level? Yeah, indication is very simple. That is this ACC AHA guidelines 2013. They say that you have to check the 10-year risk profile. There is actually an equation called pooled cohort equation. You have to online, lot of equations are available. You just you check the online websites. They give you various risk or various websites which give you risk factor analysis. So you give your age, sex, comorbidity, and you check it to click it to calculate. They will calculate and tell you what is your risk for atherosclerotic cardiovascular disease for the next 10 years. If your atherosclerotic cardiovascular disease risk for the next 10 years is more than 7.5%, you should start statin. That is all. Very simple. Okay, now previous like when to start with the high cholesterol, low cholesterol, that thing is not there now. Current guidelines say that it is based on your risk. But obviously, if LDL cholesterol is more than 190, you should start. There is no question about that. More than 190, should definitely start. Between 70 to 190, you check your atherosclerotic cardiovascular disease risk. If it is more than 7.5%, you start. A lot of calculators are available. You just check, type in the Google and you will get. Okay. Then few statins are available in the market in generic forms and a few with trade name. Is there any difference in the generic ones? Ones are much cheaper than and affordable. Actually, that is a controversial thing because the drug controller, what do you say, the drug standards in our state, we all know, or not in our state, in our country, we all know. Generic, like what I would say is from my experience, I can say that lot of these generics don't have that milligram. Like suppose you give statin 40, atorvastatin 40, you may get only some 10 or 15 milligram percentage reduction in LDL. But if you give from some good company, what is expected, we get that result. So better to, I would say, better to prescribe from the reputed companies, but then patient is cannot afford means you can definitely give generic. At least it will give some benefit. I don't know whether it is going to give the full benefit, that I don't know. Then, okay, that's all.
Thank you. If you have any other questions, please put it in the comment section. Scaria, for statin patients who are intolerant, particularly the side effects that you were talking about, let's say refractory myalgia and so on, what are the options? Are there statins which cause less of a myalgia? After that, what non-statins can be substituted?
Okay. So first thing what is advised in guidelines is that you have to stop it, and you can actually, they say that repeated re-challenges can be done, but that is not practical in our situation. So what we can do, so because only when you do repeated de-challenge and re-challenge, you can find out the nocebo effect. So that is not practical in our situation. So what we can do is, if patient developed, like the reason why atorva is having more muscle symptoms is because it is more lipid soluble. So it diffuses into your muscle and affects your mitochondria. That is why you're getting more muscle symptoms. Whereas Rosua, being a lipid soluble, being water soluble, it needs specific receptor to get inside your muscle cell. It is not there in the muscle cell. So chances less. So if you are developing a symptom with one statin, what guidelines say you stop that, you re-challenge with another low dose of another statin. Then what are the other options? Yeah, the other options is, one is you can combine a low dose statin with ezetimibe, because high dose statins have this myalgia, muscle pain, myopathy. But what you can do is you can combine statin with the ezetimibe, which is an NPC1L1 antagonist, and so it can block direct absorption of cholesterol. Another thing is, which very costly option, that is the PCSK9 inhibitors. I don't know if it's available here. It should be very costly. So that is another, but the biggest advantage is that it can be marked reduction, but no risk of hemorrhagic stroke. There is no risk. Side effects are also very less, but injection, but cost is the most important problem.
Thank you, Dr. Scaria. I think we are at 9:15. If there are no other questions, we will conclude.
Yeah.
Thank you. Thank you for the excellent session. Thank you to Dr. Pradeep sir for organizing it. Special thanks to the IMA team, particularly sir for joining us the meeting today. We look forward to all of you joining us again for the upcoming sessions as well. Pradeep sir, you want to briefly update the upcoming AMS events for this month?
Yeah, I already mentioned it once. I remind you that our next session is on 23rd. That's again a Zoom meeting at 8 o'clock. That is on tuberculosis, National TB Eradication Program, recent updates by Dr. Sanjeev Nair. It's going to be an excellent session. And on 25th, we have the basic pulmonology workshop with CM Greathouse. And on 27th, we have AMS General Club. Okay.
Thank you. Thank you, sir, once again. Good night, everybody. We will conclude the session.
Good night.